Okay, and we're rolling.
Welcome back.
Welcome back, episode 6?
Episode 6.
Episode 6. We're on the clock. We're timing it this time, so we're going to try and avoid another 20-minute video.
That's right. Where are episodes 1, 2, and 4? Nobody knows.
Nobody knows.
Nobody knows.
I think there's... I'm working on it.
That's right.
I'm working on it. It's been a busy week. So we want to talk about manual therapy.
Manual therapy.
Hot topic, fresh
talk.
off the presses.
That's right.
So why don't you kick us off? What are your main points? What do you want to get across?
Yeah, so I think we were thinking about talking about two different things. So now that physical therapy has expanded and people know that we use our hands, that we do techniques that maybe we're seeing traditionally as other providers, osteopaths or chiros, what can we do as PTs to try to change pain and movement and help people move better? And I think the way that both of us would think about that issue or that style of treatment is, do you have a joint technique and do you have a soft tissue technique? One of my favorite clinicians, Charlie Weingroff, once kind of said that, like a new grad, manual therapy wise, get yourself a good joint technique, a good soft tissue technique, have a good assessment system, and then get to know strength and conditioning or fitness medical exercise. So we wanted to break that down more specifically today and talk about...
Remember, new grads, it's just that easy.
Yeah.
Just that easy.
Easy money. But what techniques are out there, why they may or may not work to the best of our understanding, and, in the future, how we apply that and parlay that into more of like a movement system and therapeutic exercise. Why don't you give us a little bit of a quick background in terms of how we've progressed to where we are now, and then I guess we'll talk about what's cool and hot.
Okay, cool.
Now.
So, at least from a physical therapy perspective, everything can be considered a type of therapy: chemotherapy, hydrotherapy, physical therapy. So the original kind of idea was, physical therapeutic agents, heat, ice, e-stim, that kind of stuff were our wheelhouse. And, like every healthcare profession, we've evolved and grown, and, the title stuck.
Yep.
Just like all chiropractors aren't just crack 'em and rack 'em. They do movement assessments, and they do all the similar stuff. So good care is good care. It doesn't matter about the letters behind someone's name.
Yep.
So I think really a lot of the manual therapy techniques, I want to say it started overseas. Australia has a really good tradition.
Yeah.
A lot of the Nordic countries have a really good tradition.
Yep, Mulligan, all those guys.
And it was essentially, how can you use your hands and not a lot of equipment to make people feel better?
Yep.
Which, really break up into soft tissue and joint mobs.
Yeah.
So a lot of soft tissue, regardless of the instrument you're using, whether it be just straight up massage, you can, do the pile driver into someone's quads, you can use your thumbs, you can use instruments, so techniques like Graston, hawk grips, trademark, patent pending, all that
That's
stuff.
right,
So
yeah.
don't sue me.
That's right.
For using that term. And some of the generic stuff like the Edge tool from the Eclectic guys.
Yep.
Those are all ways that clinicians save their hands so they don't wear out joints and thumbs, as well as you can get different tactile sensations. So those are all ways of putting mechanical pressure onto tissue from the superficial level.
Right.
So, on a microscopic level, everyone talks about collagen,
Sure.
cross-links, adhesions, whatever. If you put two pieces of collagen next to each other, eventually they form cross-links. Whether or not we can make a difference long-term, no one's found any evidence of it.
Yeah.
So that's where a lot of the confusion comes in.
Yeah, I don't know. Tom Myers, talked a lot about how, to change the IT band, you would essentially have to park a dump truck on it for, I don't know, something like hours. I may be misquoting there, but it would take a whole lot of force for a long time and to change something like the IT band, and that clinically makes sense to me. And I think people that do manual therapy, but maybe we're not trying to change the IT band. On the flip side of it, maybe we're trying to just change something neurologically or trying to change pain somehow, and maybe that allows people to move a little better, feel better.
Which I like to say, are we changing tissue or are we changing perceptions about tissue?
Definitely, and that's where we get into the favorite argument, obviously, in terms of pain science and whether it's all in your head versus how do we affect pain. And, clearly everything coming out of that camp is very evidence-based and thorough, but I think unfortunately sometimes movement science or biomechanics maybe gets thrown under the bus a little bit.
Yeah.
Especially when you're dealing with athletics or people that are moving around a little bit more.
Yeah. All comes down to populations.
Yeah, definitely, and both are important. I know our our main mentor up at UVA talked about a big study where like Division I cross country runners, they studied every variable under the sun in terms of why they got hurt and then didn't return to competition. And the number one thing wasn't running form or biomechanics or any of that stuff. It was a fear of re-injury or a fear of competition. So, there is clearly a component of pain, and we don't want to throw that away for sure. But I'd like to think, at least I think, that we can change pain and help people move better and get more active acutely. I don't know how you feel.
Oh, I think that
when it comes to that.
all of those manual therapy techniques, I think, are really good at convincing the person that this isn't for forever.
Sure. Yeah.
And that's the delineation between like an acute injury and a chronic injury, is if you can convince someone, hey, if I do these things and then you go do this when it's non-painful and continue to do this, along with the pain science, you're getting that input to the system saying, hey, this is cool.
Sure. Well, so from a soft tissue standpoint, what are your favorite couple of techniques, or what are some go-tos for you?
I'm a big fan of contract, relax. Through and like a lot of manual resistance.
Yep.
So someone has some trouble with anterior shoulder pain when they're coming down on a pec fly. So you have them activate the opposite side, so they're actively pushing down, so that maybe there's a little bit more stability. And then you have them just do some reps where you're just having them push as much as they can comfortably through that range.
Sure.
So all of those muscles, all that tissue has to work in a variety of positions. With a similar load.
Sure.
Which, not getting into a lot of the physics of it, but obviously if you're holding a dumbbell straight in front of you with your back flat, it's not as much work as holding it directly 90 degrees
So a little
out.
bit less of a direct technique, more of an indirect, get the right stuff going.
And you can also throw in some of the mobilization with movement. I know that's what a lot of people like the voodoo floss for, is you compress some of that and you have it move through there.
Sure.
What it does...
Who the hell knows? I mean, we don't know. We don't know.
Who cares if it makes it feel better?
Agreed.
And if they feel like they can continue to train by buying some voodoo floss and doing whatever, I don't care.
And ultimately, and it's going to make the person, able to take care of themselves. So it's good. It's going to give them that autonomy back. So I think as long as somebody is not relying on you and paying you a ton of money to come in and like voodoo, band floss every single time you're in, then you're in a good spot.
Teach them how to do it themselves.
Yeah, and I know I use the Edge tool from Urson, and it's a great, I think, affordable way to do some good soft tissue work in there to try to change tone and the brain's perception of stretch, which can be multiple things. We can talk about that in the future. I dry needle, not currently, but have for a while, and there are definitely some people that I just think get a huge benefit from it. I know.
Found the most benefit for chronic pain patients.
Chronic pain for you?
Yep. People with like upper trap, headaches, like cervicogenic type stuff.
Yeah.
Immediate relief.
And I would say I probably got some of that too, and I think we know, or at least it seems like manual therapy, you need a novel stimulus.
Yep.
So, if you get a massage and it feels really good after, it only lasts but so long, and sometimes if you get a massage multiple times, it doesn't work as good. And usually a sticking a needle in somebody's, whatever, muscle-wise, is usually very new to them and a novel stimulus. And there's some research that, may or may not pan out. We're in the early stages. It's kind of 50-50 at this point in terms of why all that works. It's hard to understand. It's hard to study, like a lot of things in our world, unfortunately. But I've seen it. People love it. Sometimes you get huge benefit really quick too, which I think is fantastic. So if it takes me 5 minutes, the patient likes it, and they're up and moving and ready to do things to actually change them long term. Awesome.
Yeah.
What about joint wise? What do you like for joint techniques?
That's something I've been working on. I love just a lot of simple grade 1 through 4 mobilizations for like arthritic knees. Like a lot of my very sweet old ladies who are walkers.
No doubt.
And they're like, oh, my knees are really achy, especially after it's cold.
Yeah.
And that's one of the few things, maybe in some arthritic shoulders as well, is where like you can literally feel that sucker start to move.
Yeah, definitely.
Where you're like, and you get into it and you give it some love, and suddenly it's
joint
better.
Juice and some warmth and
some of that synovial fluid in there.
Definitely.
So I'm a huge fan of that. I read a bunch of clinical prediction rules and indications for a lot of the C-spine manips and the lumbar manips.
Yep.
And essentially the consensus I was getting was that unless there's radicular symptoms or there's signs of like an acute fracture, people get better day one visit with a manip.
Yep.
So I've been incorporating that into my practice a little bit more, and trying to get my hands back after being mostly exercise-based for a good 6 months.
Yeah.
So those are the ones I've been working on a lot. I haven't manipped any shoulders or elbows.
Yeah, that doesn't.
I've heard some results and some theories.
Yeah, I'm not as, but hey, I mean, if it works, I think some of that can work. I definitely like manipulating spines. I like cracking spines, especially the T spine. It's a very low risk, high reward situation. I'm not a big cervical manipulator, but there's certainly evidence out there that's beneficial. You've just got to find that
I've got
person
one or two that are
yeah.
easy, that like I teach students to do on me.
Sure.
And it's like, it's not okay, you're doing 3 planar things and you're here and you've got the, I just
Yeah.
like, well, okay.
Yeah. No, I agree. And I think that's the thing for both of us is probably we're always trying to find what is valuable that we can do quickly, that is very low risk, high reward, that gets people up saying like, whoa, I walked in and couldn't move my neck, to the left, and now I'm all the way over here pain free. I mean, I think that that's a beneficial thing that didn't just happen because we had a conversation about, they're feeling pain and guarding. I mean, I think there's more to it than that.
Yeah. There has to be convincing. Some people are convinced.
Yeah, but then you've got to tell the person after. That's the big thing to me. You've got to tell the person that why we're doing this is to get you to move better. It may last a couple hours, maybe a couple of days, and that what we're trying to do is to get you to load that pattern up and then educate them on some of that pain science and understand that, it's you getting over here is just demonstrating very quickly that you can do it without that big sharp pain, but you've got to do it and take care of yourself consistently, or else it may kind of come back a little bit. They can't rely on you to keep giving you their money. They've got to become reliant on themselves to continue to finish up the process.
Yeah.
Fair enough?
Yeah. Garbage in, garbage out.
No doubt about it. All right, so we're going to talk a little bit more, I think, about how we then take using these great techniques. If you come into the clinic and see him, obviously I'm not doing that stuff now, but historically for me, I'm touching almost every single patient that comes in the door for me with some level of manual therapy, unless they're, not everyone needs it, don't get me wrong, but I think most people can benefit from it. But then how do you crack a back, dry needle a trap, do some hold, relax, muscle energy technique with the neck to get back a good amount of motion. Boom, they came in here. Now they're way over here, then what do you do? So I think next time we were going to talk about how we follow up manual therapy.
Exercise selection, patient buy-in, using some of the magic tricks to convince them that they should be taking care of themselves.
Yeah, and that's definitely your bread and butter. I think you do probably a better job of that than me in terms of working all that exercise stuff in too. So we'll see what you got.
We'll see.
On the next episode.
On the next episode. To be continued?
To be continued.
Okay.
Episodes.
As always, if there's something you want us to talk about, 2 guys on a bench sitting here in this wonderful performance.
That's right.
Center.
Oh, look how sick the squat rack looks.
Yeah.
No big
deal. Give us some comments, give us a shout out, and we can ramble on that.
Cool. Yeah. Look forward to helping you guys out.
A pleasure, sir. As always.
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 Very formal. Later.